you. All right, so we're going to discuss common indications for lumbar fusions, discuss the difference between minimally invasive fusions and traditional open lumbar fusion techniques, and then go over the difference in costs, opioid requirements, and all that other good stuff that makes minimally invasive fusions better, in my opinion. So low back pain is obviously very common problem to have, a very costly problem to have, about $12 billion in direct costs for that, and that's not counting the litigation or workman's comp world. According to World Health Organization, low back pain is #1 cause of liability worldwide. It's not just in the United States, it happens everywhere else. In terms of work-related low back injuries, low back pain comprises about 1/3 of all workman's comp musculoskeletal claims. The direct costs in workman's comp world for overexertion injuries, which are mostly low back pain, are about $15 billion per year. Fortunately, most of the time it's a fairly self-limited problem. And most of the time, low back pain will resolve by itself within a month with some conservative treatment. However, 17% of injured workers will take 1 to 6 months to return to work, and 7% of patients will take more than that. If an injured worker stayed out of work more than 12 weeks, only 50% of them will actually return to work at the pre-injury level. So it is important to treat it well and treat it fairly soon. The longer you wait, and the lower the chance of successful outcomes in terms of work-related injury becomes. Lumbar fusion surgery has been growing in popularity. There's been about 60-70% increase from 2004 to 2015. There are many reasons for that. Main reasons probably the fact that our population is aging, so we have more people who need spinal fusion surgery now than before. Our techniques of doing spinal fusion surgery, as well as general anesthesia, becoming more safe, so it's easier to offer to people. And now with minimally invasive methods of doing the spinal fusion surgery, we can actually offer it to even more people than before. Because there are lower risks and a lot less bleeding, you can do minimally invasive surgery on patients who wouldn't be really good candidate for traditional open techniques. So this is lumbar spine, has 5 vertebrae in it. They're connected by discs in the front, little facet joints in the back. When we do fusion surgery, the main reason we do it is to create bony union between vertebrae. We're actually physically fusing bones together. The 2 reasons to do that are to eliminate motion, especially if there is excessive motion, and to stabilize the vertebra in the proper position if they're out of position, if there's some kind of a deformity going on or the vertebrae have shifted. So main indications for fusion surgery, obviously, first is failure of non-operative treatment. Very rarely would we do fusion surgery without having tried all the non-operative methods of treatment, such as injections, physical therapy, medications, changing activities, stuff like that. Most of the time, if we fuse in the spine, it is because it's unstable. The bones are moving too much. Most instabilities are degenerative, but you can have instability because of trauma, such as fracture, and sometimes instability happens congenitally. You're basically born with unstable spine. We also do fusions for scoliosis or other deformity when the spine structure is abnormal. We need to normalize it and put bones in a proper position. The only way to keep them in that position is to actually fuse them together. And lastly, degenerative disc disease is a reason to do fusion surgery when the disc itself is arthritic enough where motion of the disc actually causes pain. We can do fusion for that and eliminate the pain by eliminating motion of that painful segment. Is fusion effective? Really depends on why you're doing fusion surgery. If you're doing it for the degenerative spondylolisthesis with instability, success rate is about 95%, same as you would have with a knee or a hip replacement. Whereas if you do the same procedure but for indication of degenerative disc disease, your success rate is only about 70%. There are many factors that attribute to that, and there will be, wouldn't have time to talk about that, but basically, not only you need to know how to do fusion, but you really need to know who to offer to be successful as a surgeon. There are multiple studies that show that fusion works. One of the most kind of biggest studies that a lot of people rely on is the SPORT study, Spine Patient Outcome Research Trial, where they took 600 people with degenerative spondylolisthesis. 2/3 of them had surgery and 1/3 continued non-operative care. They followed them for several years, and they showed that patients who got fusion surgery had significantly better improvement in pain and function, as well as satisfaction with the results. So types of fusion, the traditional ones are either posterior lateral, going through the back, posterior intrabody when you go through the back, but you also put a spacer between the bones where the disc used to be, or going through the front, which is anterior fusion. There are such fusions as interspinous or facet. Those are controversial, do not work very well. Most insurances do not pay for those. So traditional posterior fusion involves making a big midline incision in the back, removing muscles off the bone and putting bone graft in that area so it grows a bridge of bone, as well as some hardware to stabilize everything. With posterior intrabody fusion, in addition to that, putting bone graft between the transverse processes, we'll move the nerves out of the way, remove the disc with specialized instruments, and then put a spacer and some type of bone graft material. Fusion rates are usually better, and you usually can correct deformity a lot better with the intrabody fusion as opposed to just a traditional posterior lateral fusion. Anterior fusion we do through the front. We don't have to cut as much muscle, but there you have to move intestines and big blood vessels out of the way, so it becomes a little bit more complicated. Most spine surgeons would use an approach surgeon to help them with that, which is usually either a vascular surgeon or a general surgeon. So problems with fusion, the spine is in the middle of the body, no easy way to get to it. So through traditional fusion techniques, we have to cut a lot of soft tissue to get to the spine. If we're going through the back, we're going to denervate and injure the muscles to the point that a lot of the muscles will turn to scar tissue afterwards. Cutting muscle causes a lot of bleeding, so you lose a lot of blood, and a lot of patients need blood transfusion after that, which has its own potential complications. If you go through the front, you can potentially injure the abdominal contents, such as great vessels, which cause severe bleeding, potentially death, or you injure the intestines and you have severe infection. So all of that leads to long recovery, greater pain and disability. About 1/3 to 25% to 1/3 of patients after traditional lumbar fusion will actually develop some type of a post-traumatic stress disorder because of all the pain they had to tolerate just from the fusion surgery. So because of this, there's been a drive in the past couple of decades to try to do surgery in a less invasive fashion. So that's where minimally invasive surgery comes in. We do a lot less soft tissue dissection. We have to use specialized tools and retractors for that because we don't see the landmarks with our eyes. We now use intraoperative X-ray fluoroscopy, and we use neuromonitoring and other techniques like that. The two most common ways to fuse the spine in a minimally invasive fashion is either posterior or direct lateral. So with a posterior fusion, instead of making one big incision in the middle, we'll make two smaller incisions on the sides. And instead of cutting muscles off the bone, we just spread between muscle fibers to get to where we need to get to. It allows for a lot less trauma. You don't detach the muscle off the spinous process, and you don't remove the blood and nerve supply to those muscles. So this is on the right, you'd see what a traditional incision would look like for a one-level fusion, about 4.5 inches, as opposed to minimally fusion, you got about 1.5 inch incisions, one on each side. Basically, you accomplish exactly the same work with both. So this is what patients see. This is what I see as a surgeon. As you can see on the right, with a traditional open incision, you have a lot of bleeding. You have to cut a lot of muscle to get in there, whereas opposed to with minimally fusion, a lot less bleeding. You gently spread in between muscle fibers. So it's a lot less trauma. Patients tolerate it a lot better. So these are specialized tubular retractors we use so we can actually look through them and see what we're doing. So we're still accomplishing what we need to do and do it safely. We can put bone graft and a spacer between the bones where the disc used to be, and we can use that same small incision on the side to put the screws and rods in the spine. With a lateral fusion, we instead go through the side. It's technically still considered anterior interbody fusion, but don't go through the front, we'll go through the side, but technically still get to the disc. And we go through a retroperitoneal approach, means we go behind the intestines. It allows us to avoid the great vessels, and the intestines kind of fall off to the side so they're not in the way. So this procedure I can do without help of an approach surgeon. I can do it myself. Don't really need, we're so far away from those dangerous structures, I don't really need anybody to help me get there. Because there are no nerves in the way, we can insert a lot bigger cage in there so we can have better fusion rates and can reduce deformity a lot better. It is complicated to do, so you have to have a lot more specialized equipment to do such surgery. And these are just some early studies showing the outcomes. If you do that lateral fusion surgery, your blood loss is less than 100 cc, so about 3 shot glasses, as opposed to traditional surgery, you get to almost a liter of blood loss. The discharge from the hospital is a lot faster. People can ambulate a lot quicker, and perioperative costs are actually a little bit lower because your operating room time is lower, your admission time, days in the hospital are lower, and you do not deal with complications such as severe bleeding, so you do not need to give people blood transfusions, which is also very expensive. So this is the neuromonitoring electrodes that will be all over the body. Because we don't directly see the nerves, we have to monitor nerve function so we can still do the surgery safely and not injure anything. And this is going to be, oops, a little animation kind of showing how lateral surgery works. So we are using X-ray, we localize where the incision needs to be done over the spine. Then a small probe will go between muscle fibers down to the spine. The probe is directional, so it will tell us if we're too close to the nerves, and we can reposition it so we're over the disc, but we're not injuring the nerves in the process. This is all done through a tiny incision, so we can't really see things there. That's why we use this probe to let us know where the nerves are. So once we determined we're in a safe spot, we put smaller dilators, bigger dilators over it just to open up that space more so I can actually see through it. And then we put this retractor over it and open retractor blade. So now I'm looking through basically an opening about 1 inch in diameter, which is just enough for me to see what I need to do and not any bigger. So we are minimizing the damage to the soft tissues. We use some tools to remove the disc. In real life, it does take a little bit longer than this, but it usually takes about 15 to 20 minutes, and then we can put a spacer in there to fuse it together. And we can either put this metal plate on the side, or we can put screws and rods in the back. And that's basically the entire procedure. So the benefits of minimally invasive surgery, there are a lot of benefits of it. You have about 50% improved extension strength because you're not hurting the muscles as much, so they're going to recover faster and actually have more strength. So if it's an injured worker, they're actually more likely to come back to their full duty work if you do the surgery in a minimally invasive fashion as opposed to traditional open techniques. You have a shorter hospital stay, quicker recovery and return to function, a lot lower narcotic use, so you have less chance of addiction and a lower cost of post-operative medications, less blood loss, and actually cost saving just from the shorter admission. So this study was done back in 2011. It looked at 100,000 spine cases done in the United States, and they compared outcomes of traditional fusions versus minimally invasive techniques. And basically, we're able to show that with minimally invasive techniques, we can get about 5 times lower chance of infection as opposed to traditional fusion. Even with traditional fusion, it's not very high, it's 2.4%, but those infections can be very costly with repeat surgery, so we can minimize that. It's definitely a big benefit to the patient. Another study, this was actually done in workman's comp patients, where they looked at the outcomes of workman's compensation patients versus patients without a workman's comp case, and actually showed that outcomes were the same. So, traditionally, a lot of studies showed that with traditional open fusion surgeries in workman's comp patients, your outcomes were actually worse. They were less likely to be pain-free and come back to work, but with minimally invasive techniques, we can basically get them to the same statistics as the general population. So just some more studies showing you, and there's probably more since that time, showing you the advantages of minimally invasive surgery. A couple I'd like to point out is the decreased opioid use when you do minimally invasive surgery versus traditional. In this study, people who had open surgery had significantly more likelihood of still using post-operative pain medications after the surgery when you did versus traditional versus minimally invasive techniques. Another study showing that average narcotic usage post-operatively was almost half in the patients who had minimally invasive procedure versus open procedure, and average length of post-operative hospital stay was about 1/3 less. And this study looking at MIS TLIF, once again showing lower duration of postoperative narcotic use, 2 weeks versus 4 weeks, and faster return to work, 8.5 weeks versus 17 weeks out of work after that surgery. And it makes sense. You're cutting a lot less muscle, so it's going to hurt less, and they'll be more functional quicker. Also, some studies showing the lower cost. MIS TLIF surgery on average costs about $3,000 less than a traditional open surgery. Another study showed that the difference was actually closer to $4,000 if you look at the overall 60-day postoperative period. In terms of outcomes in workman's comp and the permanency impairment rating at the end, it is still complete loss of motion in one segment, so you will still have the category 4 DRE with 20 to 23% permanent impairment if you look at the 5th edition. But because you have a lower complication rate, you're a lot less likely to get to DRE category 5, which would have even a higher percentage. So you can still make the overall potential permanent impairment lower if you do minimally invasive fusion versus traditional. So what are the limitations? Why wouldn't every doctor do minimally invasive surgery? Unfortunately, nowadays, navigated minimally invasive surgery is done by about 15% of surgeons in the United States. It is technically more difficult. You do have to have additional training. I had to take a lot of time early on in my career instead of seeing patients learning how to do this. It is not something that is commonly taught in spine fellowships even right now. It is potentially high radiation exposure to the surgeon and to the patient because you're shooting a lot more x-rays. That part is changing now because we're using new image guidance and robotics, which gets me to the difficulty of subpercutaneous pedicle screw placement and why I use a robot for that. So the pedicle screw placement, basically pedicle screw needs to go through a tunnel in a bone, which is about 20 millimeters long and 8 millimeters wide, and you have to put a pedicle screw in it perfectly, otherwise it goes in the wrong place and will injure some vital structure. With traditional open techniques, you would see exactly where the screw is going, so it was fairly accurate, but with minimally invasive fusion, you're now going through a much smaller incision, so it's a lot harder to see. And that's where using navigation and robotic technology makes the pedicle screw placement a lot more accurate. So this is the robot that I'm using. Patients get preoperative CT scan. I load it into the robot. Then I can program all the screw trajectories on that robot. So basically pre-program where the screws need to go. Then I match the anatomy of the patient on the table to what the robot knows the anatomy is on the preoperative CT scan. And as you can see, this robotic arm rigidly holds the trajectory through which the pedicle screw needs to go into, so I can't even put it in the wrong place even if I try, because the robot will prevent me from doing it. It makes putting the screws during surgery a lot quicker because you don't need to aim anymore. The robot does it for you. And it's also a lot more accurate, accuracy about 99.6%. So it's as accurate as we can get it, basically. This is just a little bit of video of how this happens. So for example, I chose this trajectory for the screw, and now the robot is orienting itself over that trajectory. You have this rigid cylinder through which you're going to put a screw in. It will hold it in that position, so you can't even put it in the wrong place. And just a little case example. This is a 35-year-old gentleman, initially injured his back while being deployed in Iraq, and had chronic back pain, and now is having more leg pain as well. So he came to me after failing injections and physical therapy. This is his x-ray showing that this bottom disc here between L5 and S1 is degenerative. You see it's smaller. You have less space between the bones than you have on the other discs. And this is his MRI showing that you also have a big disc herniation compressing the nerves. So we decided to address both problems, his chronic back pain from degenerative disease, as well as the disc herniation, but do it in a minimally invasive fashion with a robot. So he had minimally invasive TLIF procedure. He was able to go home the next day. The leg pain went away immediately. The back pain was basically gone by 6 weeks. And he actually returned to work as a chef here in a restaurant in Las Vegas. And this is just a picture of me using the robot for that case. This was actually my first robotic case in Las Vegas. And that's his post-operative x-rays showing that I was able to put this cage between the bones through a small incision on the side, and the screws and rods were placed with assistance of the robot. So now the spine is stable. There's no more pressure on the nerves. And as you can see, we're able to separate the bones apart back to the way they were before the disc collapsed. And that's pretty much it.